After that fun and the brain teases, we are perfectly back to something ordinary. And this is the clinical scenario. This is a 58-year-old male with ischemic cardiomyopathy, very poor left ventricular function, symptomatically better. That's very important. Symptoms matters in heart failure. Sinus rhythm, blood pressure is 92/58. Normal renal functions, normal potassium. And he is on the following drugs: aspirin, statin, ramipril. Look at the dose: carvedilol, furosemide, and nitrates. We should realize the fact that despite proven guidelines and recommendations of GDMT, directed medical treatment in heart failure, only about less than 25% of the patient with heart failure receive the treatment. Mainly because one of the important barriers for the implementation of this guideline is lower blood pressure. Fortunately, first, there was a lot of confusions about the definition of when will you call a heart failure patient a person with low BP. Is it same as hypotension? There was a lot of confusion, but couple of months ago, we had a directive from the Heart Failure Association of America and the European Society, which opened up, cleared a lot of apprehensions. And I'm just going to tell you in the next few minutes about that. So we have to know about what is the definition of hypotension in the setting of HFrEF, heart failure with reduced ejection fraction. Conventionally, it is said that a systolic blood pressure below 90 is, you can call it a low BP. The better is the mean arterial pressure of less than 65. Somebody may have a orthostatic hypotension. That's also important. One of the most important things you have to keep in mind when we say less than 90 is the cutoff, is whether he is symptomatic or not. That's very, very important. Our patient was not symptomatic. Again, we have to be very, very clear about the fact that the blood pressure measurements are perfect. Patient with atrial fibrillation may have problems with measuring, and at times it is even recommended that to do a very short ambulatory blood pressure measurement to confirm that this gentleman, because as you have seen, 70% of the physician's apprehension to implement a guideline-directed medical treatment is because of lower blood pressure. That's why it's important, measurement is important. Now, if you look at the prevalence of low blood pressure in very many heart failure trials, now you can see many of the trialists has used very many differing levels. But then we have no confusion now. Conventionally, it is 90 or less. And you can see that it's a larger prevalence. Sometimes it goes to 22%. It differs whether it is an acute heart failure or a chronic heart failure. Chronic heart failure, obviously, it is lesser. But symptomatic lower hypotension is something like 3 to 4%. So there lies the importance of not just the measurement of blood pressure. Measurement should be always interpreted whether they have presence of symptoms or not. It is true that the lower blood pressure in the setting of heart failure increases the death rates, but we should also realize that even if the blood pressure is less than 90, if the guy is asymptomatic, guideline GDMT matters, up titration matters, because it sort of it dampens the increase by providing early GDMT. you can even prevent the excess deaths due to hypertension. Every drug, most of the drug, not every drug, all the drugs that be the foundational for quadruple therapy, each one of them reduces the blood pressure, and the main culprit here is ARNI, then ACE inhibitor, then ARB, and also the beta blockers, MRAs, SGLT2, all of them can, but amongst the 4 drugs, SGLT2 and MRAs are comparatively safer than ARNI or beta blockers. So before you decide on, once you see that the blood pressure is less than 90, also look at other possible causes, both cardiovascular, they may have an associated diseases, or look at the drug list, just like our patient was on furosemide 40 milligram twice daily. He was asymptomatic. So you have to look at both cardiovascular related causes for lower blood pressure and non-cardiovascular causes for a possible lower BP. That's very, very important before you decide on down titrating the essential quadruple drugs. See, our patient was asymptomatic, but despite that, he was on 80 milligrams of diuretics. A diuretic withdrawal in a stable person can very well be done. Of course, you cannot possibly suddenly stop from 80 milligram to 0 milligram. You can down titrate, keep it about 20 milligrams, and then he can be, because diuretics has only symptomatic benefit. It doesn't alter the mortality, or it may. There could be a repeat hospitalization because of congestion, but then you have to be watching for that. The important thing, even if you see a blood pressure of 90, if he is asymptomatic, don't stop your foundational 4 drugs. Don't down titrate, don't discontinue. That is the most important thing that you have to keep in mind. Now, this is one of the very a large database which showed us, even in the acute setting, acute hospitalization, using all the foundational drugs, ARNI, beta blocker, MRA, and SGLT2 is eminently possible, and you can go on up titrating in the next 2 or 3 weeks to the targeted dose. And even when we do that, the chances of somebody developing symptomatic hypotension is pretty low. So hypertension with minimal symptoms or no symptoms, no need to down titrate, no need to stop. Now you may be seeing a person with heart failure for the first time and his BP may be 90. So what will you do? Again, if he is asymptomatic, you initiate with the drugs which causes minimal effect on the blood pressure, like SGLT2 inhibitors or MRA, and then see the blood pressure, and if it's stable, if it remains asymptomatic, then bring in beta blocker, and finally you can do that. You can do an individual setting. This is a little busy slide which again tells you that seeing a blood pressure of 90 should not deter you from implementing using all the 4 drugs. It may depend. It may, because if somebody has a chronic renal disease, you have to be again careful. If the GFR is less than 30, you have to be extremely careful. But it only means that you have to titrate the drug depending upon the person's. The titration business is a little complex, but I'm sure with your experience you can do that, looking at not just at the blood pressure, look at the symptoms, look at the renal function, look at the potassium level, and definitely you can bring back all your foundational drugs gradually. Of course, if somebody has severe symptoms, you may have to de-escalate it, the drugs, or even stop it, and the measures like CRT or other invasive procedures will help you to to tide over the situation. Even there are instances where people have midodrine in heart failure to tackle the hypotension. But then these are rare instances, I will say. So our patient, what I will do is taper off his furosemide, stop nitrate. Nitrates are of no value in long-term prognosis or hospitalization. Add an MRA. Up titrate the RAS blockers. He was on ramipril. I will definitely, once he is stable, I will want to change him ramipril to Arni. When you use a vasodilatory beta blocker, the chances of hypotension may be a little high. So you can change to agents like bisoprolol, which has not much of the reduction in the blood pressure is marginal when it compared to carbidopa. So basically, don't get worried about a reading of 90 or 92. Symptoms matters. If it is symptomatic or if he has a less than 80, then only you contemplate about non-implementation of the 4 drugs. Otherwise, you can, based on the patient's parameters, looking at his renal function, his potassium levels and other statuses, you can bring in all the foundational drugs in most of the patients. Thank you very much for your kind attention.